Let's look at dementia, which is a syndrome that can have many causes, but it's defined as a progressive, non reversible clinical syndrome marked by a decline in previously acquired cognitive functions without loss of consciousness. It affects about 5% of the people over 65 and 20% of people over 85 years of age. And the most common types of dementia are Alzheimer's disease and vascular dementia. So, dementia can be classified as cortical and subcortical, where in cortical we have Alzheimer's disease and frontotemporal dementia, vascular dementia. But in subcortical disease, we have diseases like Parkinson's disease, Huntington's disease, etc. Then we look at some causes of dementia where reversible causes, irreversible causes, and psychiatric illnesses are there. So, reversible causes you can remember by a mnemonic or as high T with normal sucker Brad, where hypothyroidism, thiamine deficiency, vitamin B12 deficiency, normal pressure hydrocephalus, subdural hematoma, chronic infections, brain tumor, autoimmune encephalopathy, and drug intoxication are there. Irreversible or degenerative dementias include Alzheimer's disease, which is the most common, frontotemporal dementia, Huntington's disease, dementia with Lewy bodies, vascular dementia, leukoencephalopathies, and Parkinson's disease. Psychiatric disorders like depression, schizophrenia, and conversion reactions can also present as dementia, but especially for depression, when features like dementia is there, it is called pseudo dementia. Now moving on, clinical features. Of course, they show signs of memory loss and personality changes, but loss is not the most defining feature of dementia. So, thus, the assessment involves comprehensive history taking from the patient and the family. Besides tests like MoCA, which is Montreal Cognitive Assessment, and mental state evaluations to rule out depression. Specific types show distinct features, and we'll see about them. So, Alzheimer's disease, which is the first presenting symptom, is memory loss or episodic memory loss. Shows irritability, anxiety, and depression with no neurological deficits initially, and imaging showing entorhinal cortex and hippocampal atrophy. While in frontotemporal dementia, the presenting symptoms could be apathy, poor judgment, speech, language, and hyperorality. Mental state will show frontal and executive or language deficits, and drawing usually spared. Then, neuropsychiatric symptoms include apathy, disinhibition, overeating, and compulsivity. Now, they show vertical gaze palsy, axial rigidity, dystonias, alien hand, or motor neuron deficits. Imaging will show frontal and insular or temporal atrophies, usually spares the posterior parietal lobe. Now, dementia with Lewy bodies, they present with visual hallucinations, REM sleep behavior disorders, delirium, Capgras syndrome, Parkinsonism. Drawing in frontal executive deficits, memory is spared, and they are prone to delirium. They will show present visual hallucinations, depressions, sleep disorders, and delusions. Features of Parkinsonism is present, and the imaging will show posterior parietal atrophy. Hippocampal is larger than Alzheimer's disease. Now, Creutzfeldt-Jakob disease, which will present as dementia, mood and anxiety changes, movement disorders. Variable includes frontal, executive, and focal cortical dysfunctions, depression, anxiety, psychosis in some cases. Myoclonus, rigidity, and Parkinsonism are the neurological deficits, and cortical ribboning and basal ganglia or thalamus hyperintensity on diffusion MRI is seen. Now, vascular dementia is often sudden onset and variable symptoms like apathy, falls, and focal weaknesses. Have frontal executive dysfunctions, cognitive slowing, and memory can be spared. They show apathy, delusions, and anxiety, and usually motor deficits with spasticity can be seen, or they can be normal, but the imaging will show cortical and subcortical infarctions and confluent white matter disease. Moving on, the investigations, as there are a lot of causes, will include obviously a lot of different tests to rule out the underlying condition so that we can treat the patient and predict the prognosis. So, there are some routine investigations that should be done where patient history and examination are a must, with thyroid function test, vitamin B12, complete blood count, electrolytes, and CT MRI to rule out some. Again, all of these tests are done to rule out the reversible and irreversible causes so that we can focus on the diagnosis that will allow us to decide the prognosis of the patient. With some optional focus tests that can help our psychometric assessment, chest x-ray, lumbar puncture, liver function test, renal function test, urine tox screen, and HIV testing, apolipoprotein E testing, which is a marker of Alzheimer's disease, RPR-VDRL for syphilis-related encephalopathies, HIV again encephalopathies, EEG for seizure activities, parathyroid function, adrenal function, urine heavy metals for chronic poisoning, erythrocyte sedimentation rate, ESR for inflammatory and vasculitis, angiogram for vascular dementias, brain biopsy, which is mostly post mortem confirmation, SPECT scan, which is done for liver body dementias, and PET scan, which is done for active metastasis, antibody testing for vascular dementias again. After all these investigations, when the final diagnosis is found, then we can move on with the management plan, which focuses on treating the underlying cause and supporting the patients and the caregivers. Caregivers form a major part of these management plans because these are the diseases of mostly geriatric population, and these people can not take care of themselves. So a lot of government and legal framework can is also needed to take good care of these patients. And some drugs like psychotropic drugs also help, and there are special indications for them with special types of the dementias. But risk factor control as a general in a general population for hypertension and alcohol abuse can actually help with slow decline of the disease in the diagnosed patients and reduce the incidence of the disease as well. So we'll move on to some tests that are done for the cognitive assessment, which is Montreal Cognitive Assessment Test, where the investigator will sit with the patient and ask them to follow few commands, and then will score them on the with some points where the aggregate is a total 30, and a score more than 26 is considered to be normal. Now, the mini mental state evaluation, where which is also important for Alzheimer's disease, is again a very similar test where the examiner will sit with the patient and ask them a series of questions and tell them to do a certain task, and will grade them with scores. So there's a score range for this, where a normal score of 24 to 30 is expected, but if the score is between 20 to 30, 23, mild cognitive impairment is possible, and 10 to 19 means a moderate Alzheimer's disease, or and 0 to 9 as a severe Alzheimer's disease. Again, note that this is not the diagnostic test, but just a screening process, and the confirmatory diagnosis is only post mortem after brain biopsy is done. So we'll move on to Alzheimer's disease, where which is this is the most common type of cortical dementias. Genetic factors contribute to about 15% of the cases, and there are two types: early onset, autosomal dominant, and late onset, which is polygenic in inheritance. Then there are possible defects in protein degradation. The brain will show atrophy, especially in the cortex, not the full cortex, but mainly in the parietal and temporal lobes, and the hippocampus, where nucleus of Maynard basalis is the most affected. Now, the earliest and the most severe damage is seen in the medial temporal lobe or entorhinal cortex, And histological features we'll see in a few seconds will show senile plaques with amyloid and ubiquitin and neurofibrillary tangles. Now, the neurotransmitter deficits are notably cholinergic, but also noradrenaline and serotonin, glutamate, and substance P. Now, mutations will include amyloid precursor protein, which is often associated with trisomy 21, and where presenile onset is seen, as the patients may get affected with under the age of even 35 years. And other mutations include presenilin 1, which is associated with chromosome 14, and presenilin 2, which is associated with chromosome 1. And these mutations are implicated in over 50% of families with familial Alzheimer's disease. Now, ApoE4 allele, which is associated with chromosome 19, increases the disease risk by 2 to 4 times in heterozygotes and 6 to 8 times in homozygotes, but it is neither necessary or sufficient for the disease. Clinical features. These patients will present with a classical 4 A's: amnesia, apraxia, aphasia, and anosognosia. So, amnesia will start with episodic memory loss, progressing to short term, and then long term memory loss also affected. So, these patients will start missing out on silly tasks like not able to find the spectacles or the books that they kept somewhere, to big memory problems like not identifying family members or going out in the market and not coming back and just sitting outside, and some other people will carry them to their house who know them. So these are the features that when a caregiver identifies, they bring them to the doctors, and then the whole investigations will follow, and then treatment plans. Other symptoms are apraxia, visuospatial issues, aphasia, and a denial of illness, which is anosognosia. Then dyscalculia, rigidity, and mutism can also be seen later, incontinence, and finally incapacitated bedridden state. So these patients are often brought by caregivers, and one of the things that these patients will be very unhygienic because they don't know how to take care of themselves, and they may present with depression and aggression also. So diagnosis completely relies on progressive memory loss, which is confirmed by informants, cognitive tests, and imaging are supportive but not definitive. So now the pathological features. You can see that cortical atrophy is evident on the right side where meninges have been removed. Then the plaques with dystrophic neuritis surrounded by amyloid cores are visible. And in a silver stain, the black tangles are the neurofibrillary tangles within the neuronal cytoplasm is present. And then the tangles and plaques with contain tau protein are seen under immunohistochemistry. The thing about neurofibrillary triangles is that they're directly proportional to the severity of dementia. We move on to investigations, where the investigations is basically focused on excluding the other reversible causes of dementia, and follows a screening with MMSE, which we've already discussed. Functional MRI is the investigation of choice, as it helps in identifying the metabolic functions going on in in parietal and temporal lobes. Then MRI may not be as useful because it shows results in very late, and may also show pseudo enlargement of the ventricles because of gray matter being thinned out. Histological confirmation is usually a post-mortem thing. Now, for managing, so general management is, of course, a lot of care given to supportive management, where different bodily functions which are deranged can be aided, like adult diapers if incontinence is there, and an overall care to the patient's environment, and the deficits that they are having should be catered. Special facilities just for these patients can be made. So medications, anticholinergics can help, and donepezil is the one of choice. Those patients who show early cognitive decline, mementin, also an NMDA antagonist, can also help with early and some advanced cases. Experimental drugs like secretase inhibitors, which target amyloid plaques, can be used. Non-drug strategies are very important, that involves familiar environments and caregiver support. Comorbid depression should be treated with antidepressants if present. We'll move on to frontotemporal dementia, which includes multiple syndromes involving behavior and language impairments. This is usual onset after 60 years. Now, there are three subtypes: behavioral variant, which is also very common variant and called the Pick's disease, and primary progressive aphasia and semantic disease. So these patients, when they present with a lot of personality changes, and they're very, very aggressive. They have language disturbances, in temporal lobe, and memory is relatively preserved, but they show echolalia and echopraxia, which are when whatever you try to say to the patient will say to you, and whatever you try to write, the patient will write. Then there are some genetic mutations that are associated with FTD as MAPT, GRN, DPD, etc. These mutations lead to abnormal protein accumulations, which are tau, which are seen as cytoplasmic inclusion bodies. And FTD shares pathogenic similarities to ALS. So management, there are no specific cure is available, but SSRIs can help manage disinhibition and compulsive behaviors, which is one of the major problems that these patients have. Now, treatment obviously differs from Alzheimer's disease because they don't have as much as cholinergic system involvement, which is seen in Alzheimer's. Lewy body dementia, which is again a neurodegenerative condition where features of dementia and Parkinson's disease are seen. It is often inherited with mutations of alpha synuclein and beta synuclein genes, which causes abnormal accumulation of alpha synuclein protein, and often ubiquitin, which is inside neurons. Cognitive symptoms fluctuate with visual hallucinations, and these patients are very sensitive to anti-Parkinson's and antipsychotic drugs. So, but there's no cure per se. But again, anticholinergic drugs can help slow the cognitive decline. There are some tests to confirm this disease. Polysomnography, because these patients will having REM cycle sleep disorders. Then CSF analysis for presence of alpha synuclein oligomers, and phospho tau 217 levels to if it's elevated in the CSF or blood. MABG cardiac scintigraphy is often done. Then dopaminergic transporter imaging, which is one of the diagnostics, is PET or PET scan, is done. Now, vascular dementia, which is the second most common cause of dementia. So what happens is there are infarcts that form inside the brain that leads to this. The risk factors are male sex, advanced age, diabetes, hypertension, and other cardiovascular diseases. The thing is that this disease will have a very abrupt onset, and it's followed by stepwise deterioration, which is very classical. The findings on neurological examination consist of is consistent with prior strokes, infarcts, and cerebral imaging. Focal neurological symptoms include pseudobulbar palsies, dysarthrias, dysphagias. Now, physical examination, we see increased tone, exaggerated deep tendon reflexes, and Babinski responses. Uh, Carotid bruise, fundoscopic abnormalities, and enlarged heart can also be seen. Gait apraxia or magnetic gait can be seen. An MRI will reveal hyperintensities and focal atrophies suggestive of old infarctions. Treatment will obviously first increase will include the controlling the risk factors for hypertension, smoking, hyperlipidemias. Antiplatelets and statins can help with infarction and correction of sources of emboli, and ardectomy and anticoagulant therapy can also help. Now that we have seen so many causes of dementia, we can say that dementia is not actually one disease, but it actually has a lot of causes and syndromes under it. Thus, we can say that when treating dementia, the goal should be what to find the clinical diagnosis and then isolate the components of dementia syndromes which are treatable or reversible. Then we have to give special focus to elevate the burden on caregivers, because after all, those are the people who will be involved with these patients and will be giving them care day in and day out. So that sums up the topic of dementia, and feel free to ask your doubts, and thanks for watching.